Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. As you know, if you've watched my show before, every week we have a different guest in the program that talks about a healthcare issue or a service that we offer here at KRMC. I've got an exciting guest on the program today. I think it'll be of interest to you and your family. So stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Tim No. He's a physiatrist. Sorry, I keep trying to get that right. Brand new here at KRMC. Welcome.
Thank you.
Exciting to have you in Kingman and to be on the show so quickly. That's awesome. Now, I know that one of your primary focuses right now is getting that acute rehab filled, right?
Exactly. Well, I've been having a lot of luck and success mainly because, number one, the community is great. Our physicians here are very motivated and energetic. They do want to work hard for the patient. Just to name a few, Dr. Montero, Dr. Nguyen, Dr. Lung, Dr. Spencer, and as many as great physicians I met in the hospital.
Good.
Very supportive, very collegial.
Good.
And so there's a big rehab needs here. And
Yes.
I was training in an institution where I wouldn't say see all, but I see a lot of severe cases from brain injury to spinal cord, to stroke, to Parkinson, to multiple sclerosis, to cancer, metastasized everywhere. And
So all of those types of prognosis are patients, potential patients for the acute rehab.
Right now we starting out, so the resources office is limited as far how much care I can give them.
Sure.
So therefore that's why I create a consult service here to see the patient while they're in-house to see if we have the capacity, number to help them, and number two is to see they are a candidate for rehab. So the definition of acute rehab is 3 hours a day, 5 days a week. And if you
to
can
be able to exercise or to do physical activity.
Yeah. So the main thought behind this is every time you come to the hospital for any reason at all, there's the medical issue and there's the functional issue. The medical issue is you come in with heart failure, pneumonia, hip fracture. Obviously, after the surgery, you are not going to be back to the baseline function.
Right.
And that's my job where I come in and assess that to see how much function you have prior to before and how can I help to bring you to that level.
Great.
So you can return home with family to have enjoy quality of life from that acute illness or injury.
That's great. Now our acute rehab has just moved over to the new facility at Walpi Mountain campus, so that's pretty cool. It's over on Santa Rosa. So that's we've had our IT, our computer guys have been there for a while, but this is the first medical service that we're providing over at that campus now, so it's pretty cool. It's on the second floor? Is that right?
Floor.
Okay.
Yes, love it. The facility is pretty much spotless. It's new, it's clean, it's very nice. Every patient get their own room. To me, I can compare like more like a 4 or 5 star hotel of the hospital.
Very good.
Yeah, so patient over there, we have a PT team, OT team. I'm bringing in speech and RT as well as the whole nursing staff.
So we're gonna let's go back so people, if they don't know what PT and OT.
Oh, I'm sorry.
No, that's okay. So physical therapy. Occupational therapy,
Yep.
speech, and what was the other one?
Speech language and RT, respiratory therapist.
Respiratory therapist, okay. So all of those are kind of the team that work together to help provide that patient?
Exactly.
Okay.
So the daily flow is usually for a patient after, let's say, a spinal cord injury, stroke, or a hip fracture would be in the morning, the OT will come and work with you, help you to get up, comb your hair, brush your teeth, and kind of adapt to the normal routine.
Functions again, right?
And the OT, and after you have breakfast and OT.
Oh, that's all before breakfast.
That's very more, it's an early day for everybody.
Coffee first.
Including for me too. So then after that, the PT will come in and work with you with getting you up on your feet, walk on a parallel bar, get you to be stronger, increase your gait stability to make sure to avoid future fall prevention. Let's say you come in with a hip fracture.
Yeah.
And after that, the speech trainer will work with you if you have cognitive deficit, memory deficit, or anything relating to the cognition. The speech language therapist will evaluate. And they also work with patients who are dysphagic. That's mean you have a stroke, you can't swallow, and they will work with you to help you regain that that function. My end is when I see you every day, just to be frank and blunt, I check for poop, pee, and pain.
Yeah.
So basically, I check to see how much pain level you have to make sure I can control it with medication or modalities to help you be able to participate with therapy. And the second part is make sure your bowel's moving okay.
Yep.
Because when you're on a lot of pain medication after surgery, a lot of times the bowel doesn't move.
Or if you haven't been physically active,
exactly.
too, that'll plug you up.
Jamie, you are awesome. You exactly. Our body is used to standing up. We use in standing position, walking. If we're in bed all the time, statistics have shown, if you've seen it, correct me if I'm wrong, usually if you stay in bed the whole day, you don't move, you lose about 3 to 5%. But this is old research. I have to look up the latest paper. And if you just do the, rough addition, then you lose a lot of functional strain.
Yeah, it just makes sense.
And, the heart, the bowel, and the bladder, the kidney, the lung, they all need to work in a standing position, walking position, or you're ambulating.
Makes sense. I mean, that's the way God made us to be on our feet, right?
Exactly. So the three things top of my head I avoid is, UTI, urinary tract infection, you stay long and your bladder pull and become a medium for bacteria to grow. Pneumonia, if you
want to avoid those things.
Exactly.
Yeah.
And then a pressure ulcer if you stay in bed too long.
Yeah, from laying in bed one spot too long.
And
none of those are good things.
No, they're not. And they're very costly, and they cause a lot of discomfort and difficulty for the patient.
So that's going, and I know that the acute rehab unit is kind of set up almost like, I don't think it's all working yet, but it's going to have a little apartment so you can learn how to how to make a bed again.
Exactly. With the OT in there, there's a bed, there's I think the
some
kitchen.
guys may have never made a bed in their life, but
there's a
new thing.
Yeah, there's a kitchen in there, but I don't think they let you cook in there though. I
Not
tried.
yet. I think they're waiting for
pretty much
approval for a new hood or something. I heard. But
exactly.
eventually, they're going to be able to learn how to cook too. This could be a whole new thing for men.
Yeah.
Learn how to cook your own meal, make your own bed, do your own laundry.
That probably take more than like 2 or 3 weeks.
Probably. Yeah. Is that kind of the average stay? Is about a couple of weeks?
Yeah. So typically the average expected stay is around 11 days. It depends on the acuity of the disease. I mean, obviously we're not talking about PT, OT here. I mean, they are the main core, but we're talking about like the overall of the patient, their mentation. For example, I have one lady, she's on 2 feet because she can swallow, and with that, and now she has to go to all these doctor appointments. So now we have to adjust the 2 feeding to bolus. That means so it correlates with breakfast, lunch, and dinner instead of running continuous feed like that. And we have to make sure the residual volume is not coming back up. And so there's more to it. Just mainly try to make the patient as comfortable and as functional to their most potential level.
Right. Get them back on their feet and moving. That's awesome. Because a lot of times I think, and frequently, we get patients that get sent to Vegas, for instance, if they've had a severe stroke, because we don't have a neurologist on staff right now. But even if they're here, they have the injury, like you said, a hip fracture, something like that, and then once they've gone through the initial medical treatment, then getting them back to normal so they can take care of themselves at home, because we don't want to send them home and then have them fall again, or those kind of, especially if they're alone, don't have family members. We have a lot of that too with our senior population here.
I'm very direct, because when I do my consult, that's mean the team asks me a question: is patient appropriate for acute rehab? I come in, I evaluate the patient, and most of the time it's going to be the same speech where I tell everybody I have a window. That window is if you can think about the patients who are too sick, where I don't think they gain any function improvement with me, I won't accept them.
Okay, well that makes sense, and you do that for their benefit too.
Exactly, and the patient who are too well, or let's say like after surgery for elective procedure, they got up, they start standing, start doing, so they can go home with home health. PT can come to their house, so they don't need my service. It's those who are in between where they severely decline function but has the potential to get to that point. Just they need someone to monitor them, help them both medically and physically. Then that's why I come in and I provide my service.
Very good. And I know we have 12 beds, is that right?
We have 12 beds,
12 rooms?
but the next step is I'm talking with administrative and as well as the great support from the hospital to push it to 18 beds eventually.
Very good.
So,
Well, I know that you've been doing a great job of getting out and introducing yourself to the other physicians, because that's always important. Because normally, I mean, a person doesn't refer themselves to acute rehab, right? You have to have a physician referral to get into acute rehab.
Exactly.
So it's not like someone could say, hey, you know, I think I had a stroke. I want to know. I'm just kidding. No, they would do that. But so they would get the referral probably while they're in the hospital.
Exactly.
From their primary care physician or the hospitalist that's taking care of them, and that would refer them over to acute rehab. So your relationship with the other doctors is obviously critical.
Exactly.
And you work very closely with them because it's their patient that they're kind of turning over to you, right? For their care? Am I kind of close?
Exactly, you're right on the
Okay.
dot. So a lot of time I take patients from other facility too, where if number one is typically when I take a patient, this is a patient I have taken care of before during my training. I feel comfortable, I take care of them. When something go above and beyond me, I always call for help. I know my limitation.
No, that's good.
And so the dynamic between doctor and doctor, I try to keep it professional and timely. Mainly if they ask me a question, they have a consult for me, I try to get the answer done by the next day.
That's great.
To make their planning process and their management as smoothly as possible for them. And a lot
and
of
the patient.
exactly internists like and hospitalists and orthopedists like Dr. Allen have consulted me a lot for their patient.
Great.
And I always try my best to provide my service.
Super. So you're a physiatrist.
Physiatrist. Yeah.
Physiatrist. I don't know why I have a hard time with that word.
Physiatrist,
Is that
psychiatrist, podiatrist, we also know the same, but physiatrist, yeah.
So what exactly is that specialty?
Especially, I think it, so physiatrist as PMNR, stands for Physical Medicine Rehab. The history from my very basic understanding is that after, I think, World War II, a lot of veterans, they come back and they still have a lot of functional limitation like amputation.
That's another one that we didn't talk about.
Yeah, I also take care of amputated patients. And so initially the two main branch of medicine, pretty much internal medicine and surgery. And so they manage all this patient. Eventually all the subspecialty, I think, evolved from that. And PMNR is one of them. PMNR is a dual head. Dual head, I say that because the physical medicine part is closely related to in the more musculoskeletal world.
Okay.
And the rehabilitation part is closely related to the inpatient part.
Okay.
And I'm sorry, you doctor out there watching this, I might be saying completely wrong, but this is my gross understanding. I know it's the combination of, like the people who do physical medicine and rehab, they combine, they have a meeting, they join together, and that's why the field developed. But just for the gross understanding, and I also do outpatient too, EMG evaluation, as well as musculoskeletal injection in the peripheral joint.
Very good to know. So do you have an office at your work?
I do. I work with, my office is in with Dr. Stan Allen here.
Oh,
I came in outpatient.
Yep, so you're in the Medical Professional Center.
Exactly, yeah.
I think is that Suite 108, maybe? I'm not, or 102, I think. But anyway,
I think so, yeah.
When someone comes in the front door, it'll say the suite number.
Yeah.
And they'll find you that way. But that'll be good. And I know you're going to have a page on our website, so they could go there if they wanted to learn more about you. But speaking of learning more about you, I know you shared before the show you were born in Vietnam, but you moved over here to the States when you were 8.
Yeah.
And where did you go to first?
So during the...
like when you're growing up?
I was growing up, when I came here, I stayed in California.
Okay.
Southern California, Garden Grove, Santa Ana, that part, yeah.
LA area kind of?
Yeah, LA area, Orange County, exactly.
Okay. And then you
I went high school, undergrad. I always wanted to be a doctor.
Oh, yeah? Good.
I just, for me, I feel just when I was in Vietnam, I lived with my grandfather.
Okay.
And he always taught me the morality and to help other people.
Good.
And at that point, I just thought, I want to be a doctor because I want to contribute back to, society, basically.
Very good. Okay. Well, I think we're going to take a quick break, but then we'll come back and we can talk a little bit more about your education, where you went to school, and all that good stuff. Okay? So stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Tim No. He's a physiatrist at KRMC, the very first one. We were talking about that during the break.
Yeah.
We've never had a physiatrist here at KRMC before. And your specialty that you focus on is primarily the acute rehab, which is getting people back to on their feet
basically,
and helping them get back to the quality of life that they had before either their stroke or their amputation or whatever the illness was that kind of put them down and out for a while.
Pretty much like maximize their functional capacity, what they can. I mean, obviously, if a patient after a spinal cord injury,
they're never going to be 100%.
Exactly,
right?
But I'm trying to help them to become as functional as they can, to able to provide self-care or become least amount of, or they would require the least amount of help as much as they can, basically.
Well, and I know even, because I've seen the patients when they used to have acute rehab over in the main hospital here, they help them learn how to use a walker again, or if they've had an amputation, getting in and out of a wheelchair, those kind of things. Like you're saying, the functional parts of living
Exactly.
that they need to be able to hopefully do as much as possible on their own without caregiver help.
Some of them, like even the simplest, let's say the patient is the paraplegic, quadriplegic, they go home. Even the basic thing like having a ramp into the house.
And how to maneuver.
Exactly, and now the chair, how high the chair should be, how big should they be, and do they, depend on the level of the injury, do they need a motor wheel, a power wheelchair versus a manual one. So those some
and I just thought of something. Do you work with like family members or their caregiver to help with that too? Because they're pretty impacted as well.
Yeah, exactly. So I think usually the family are as impacted as the patient. So a lot of time, if we do a lot of family teaching and training.
Good.
And I do family conference. If you come to my unit and become my patient before you go, I hold a family conference.
That's good.
To make sure all the therapists have and the nurses will teach the family all the technique, the skill, let's say simple bowel and bladder care. And so those are the technique and how to get in and how car transfer, assistant
those
engage.
things are important.
Get in and out of the shower
and
and
things that we
grab
take
bar.
for granted
Exactly.
on a normal, you know, when we're when we are fully functional and then it goes away, we kind of take those things for granted. You don't think about how you get in and out of car. You just do it.
Exactly.
Until you can't, and then you need some help.
And even with the help, like how is the other person going to help? What is the right technique?
Yeah, so they don't hurt themselves.
Exactly.
Right.
Or hurt the patient.
Right. Yeah, that's a good point. So that's all with acute rehab, but we were before the break and we got interrupted. So I want to come back to talking about you a little bit more. So you grew up in California after you moved here from Vietnam, and then where did you go to medical school and all that good
I
stuff?
went undergrad at UCI, and at that point, after I finished undergrad, my friend told me about Ross, a Korean program, and I was in the middle of my application, a little bit late in the cycle, so I just like, okay, I'll go to Ross, and I stayed there.
Now, what is that, Ross?
Ross is the Caribbean school, School
yes.
of Medicine.
Okay, very good.
And I went there, and I do my basic science there.
Okay.
And I came back to Miami for roughly about, I think, a little bit less than a year.
Okay.
For my first part of clinical training, and I went to New York for my remaining part of training, and I went back to California for the completion.
Okay, so you've been around the country.
And then the University of Kentucky for my residency.
Residency, okay, University of Kentucky. What hospital is that?
Chandler.
Okay, very good. And then how did you pick Kingman? Or did we pick you? No.
No, I chose Kingman. So I want someplace near to home but not close to home.
Yes.
And I was looking around, and somehow I called and I talked to a recruiter, Miss Ryan Hampton. She's wonderful, very nice, very friendly. And we talked a little bit, and we basically, she presented hospital need and how I can contribute. And
you
so
came here and just fell in love with us.
Yeah, pretty much. And why I picked this by mainly because I think the motivational factor, because I come here, I understand there's not been a lot of resources for rehab yet, and I plan to work on that.
To expand the program, that'd be great.
And you know, people say the typical, what what motivates people to do certain things. For me, I always tell everybody around me is the number one is autonomy. You get to design what you want to do, and number two is the mastery. You master what you do.
Okay.
And number three is the purpose, knowing there's something greater than yourself out there, and you want to contribute to that.
Very
and I
good.
think those three criteria. When I round here, I see the facility, not round, but when I visit here, I see that.
Right.
And as we're speaking right now, I'm working on building a strong rehab unit over there at Wallapai Medical Center.
That's great. That'll be great. And we said they just moved over there. They're only about 2 weeks, I think, maybe 2 or 3 weeks. So that's great. And they are in that beautiful new facility. And part of the reason that we moved acute rehab there is, of course, it was a beautiful facility that was kind of sitting empty, but cost-wise, it didn't make sense for us to reopen the entire hospital. Very expensive when you have to have all the ancillary services of pharmacy and x-ray and lab and all of those things.
You got it.
Yeah, but acute rehab is kind of standalone, right? I mean, it doesn't need, most of the time, the patients get to you, they're through the worst of their illness.
Yeah, so basically, in frank terms, the dust has settled, or the storm has slightly passed, and now it's just the cleanup part. That's my analogy, and I take care of that. Obviously, we do use the hospital services.
Sure.
I mean, the patients here for inpatient, they come straight to me. The acuity is, the patient's stable, but the complexity is still high for the patient. So my point is that if I ever need a specialist, a nephrologist, a pulmonologist, internal medicine, or
call and they'll come over.
Exactly. I consult them, they come over, and that's part of the patient care.
Sure.
And while you're on my unit, the nurse staff will take care of you. They'll be nursing 24/7, and in a day I round on my patient once. If you're not in trouble, I would joke around my patient. If you want to see me once, that's mean you're doing well. But if you're in trouble, I come to your bedside more.
If you see me more, then not so good.
I mean, just me coming in being goofy, say hi, that's fine. But if there's something going on with you, like you have an infection or you're running low on your blood, I have to do something about it, then you see me more. I'd come and check on you, make sure. Bringing people over is I think it's called, what we say between the two challenges, be the easier challenge. Keeping them there and let them complete the whole rehab course to get back on their feet and go home with their family. That's the challenging part.
Sure, absolutely. And then do you have like a graduation party when they get to leave?
Oh, I just tell them, hey, you graduated, and they go, yay, I'm going home, and then we sign our car, we hug and kiss, and I mean, wish I could. Other than that, they go home, everybody's happy.
With that kind of a stay, 11, you were talking average is 11 days, so you get to know that patient pretty well, almost develop a personal relationship with them. So you are celebratory when they're able to go home. That's a big thing, right? And I know that, I don't know if you know this yet, if they've told you, but they have once a year, they have like a party and bring back all of the folks that were there that graduated from acute rehab. They do. They have a little party.
Awesome.
I think it's right after the first of the year. I don't remember for sure. You'll have to ask. But they bring back all the previous patients. They have cake and, just can encourage each other. And because that's the other thing is.
I hope they invite me.
They better, yeah. But if you have, again, when you've been in the hospital for that long or in that unit for that long, you develop a relationship with the staff and the other patients too, because I bet the other patients are part of your cheerleading, right? Yeah,
one of the main thing for me is when the patient have their breakfast, lunch, or dinner, I want them to go to the common room where they interact with other patients, and that will help them in a way psychologically to feel they belong and
get them back.
It's this community idea that brings them back to the social aspect of it, and if you just do therapy, you put the patient in a room, they stay in the room all day long, and after that it makes them a lot anxious and depressed, and they look at all the problems they have, they think about it more, and now they can't sleep, and the pain kick in. And
well, thank you for being on the show. Thank you for coming to Kingman. We're excited to have you here.
Glad to be here.
And I'm sure I'll get to have you on the show again after you've been here for a while. You'll have more things to share. So thank you for joining us today. I hope you learned something new. I know I did. We'll see you next week with another great guest.